Hello, everyone, and welcome to another episode of Arthritis at Home. Today, we're joined by Dr. Sahil Koppikar. He's a rheumatologist at the Women's College Hospital and assistant professor at the University of Toronto. He's also the director of the Timmins Arthritis Clinic, which delivers remote services for patients in person and virtually. And his interests are in utilizing virtual care, digital tools, and expanding the scope of arthritis health professionals to improve access to care and outcomes in remote and underserved communities. He's also the chair of the Ontario Rheumatology Association's Northern Ontario Committee, and it's particularly with that last part of his lengthy job title that we want to focus on today and speak with him. Welcome, Dr. Koppikar.
Thank you, Kelly. Thank you for having me.
Of course. Do you mind if I call you Sahil?
Sahil's completely fine.
Great. We actually have been working together this fall, full disclosure, and that is on a project that ACE is working on, along with the Arthritis Patient Advisory Board of Arthritis Research Canada, the Canadian Arthritis Patient Alliance, and the Canadian Spondylitis Association. The four patient organizations in Canada have been conducting what we're describing as virtual summits. We're meeting with provincial governments across Canada. We've met with 5 so far in New Brunswick, Ontario, Manitoba, Saskatchewan, and British Columbia to talk to them about models of care for arthritis, particularly inflammatory arthritis, and how they can improve those models of care. And I think before we start, Sahil, maybe just a brief definition of what we mean when we talk about models of care. And that includes sort of every key step or element of a patient's journey. And that would include the early identification of the disease, whether on the part of a patient or on the part of a healthcare provider, getting a timely diagnosis, getting timely access to a rheumatologist or an arthritis health professional, medical disease treatment and management, including medications like biologics or biosimilars, and ongoing shared care as part of an overall healthcare team that's working with the patient, and finally, patient self-care. And as it relates to the work that we've done in meeting with some of the elected officials and senior bureaucrats in the provinces, we have collaborated with the Ontario Rheumatology Association, and particularly you, Sahil, in some of these meetings. And you've been able to, I think, paint a really sharp defined picture for those government officials and policymakers about the situation in Ontario right now, particularly Northern Ontario. And I'd like to ask you a few questions about that. So just to start off, what does the landscape look like for patients and healthcare providers in the arthritis community in Northern Ontario?
I think when we look at various provinces across Canada, but specifically in Ontario, there are regions where there's significant lack of rheumatologists and access to rheumatological as well as musculoskeletal care. And in Ontario, our eyes turn northward, like you mentioned. That's due to a significant lack of rheumatologists in the province. So if we look at Northern Ontario, it's the largest landmass of our province with a significant amount of population. And in the Northwest, we have one rheumatologist in Thunder Bay who's been there for a long while and not many years away from retirement. And in the northeast part of the province in Northern Ontario, we have 3 in two in Sault Ste. Marie and 1 in Sudbury, 2 who are new graduates, and that's about it. There's a few that travel up, like myself, but really just 4 rheumatologists for the entire north. And this, as you can expect, results in poor access and outcomes right across the board.
What does that mean for a patient in terms of wait times? And I'm thinking particularly for those patients with inflammatory arthritis.
Right. So it's really important to in rheumatology to think about the inflammatory diseases because of that short window that we have to diagnose and to treat. Because if we're out of that window, as we all know, the horse out of the barn, it's hard to reverse the damage. It's hard to get on top of it and results in long-term poor outcomes. So getting that patient to be assessed by a specialist, rheumatologist or another healthcare professional who has training in rheumatology is important within those first 6 to 12 weeks. And in Northern Ontario, we're way past those first 6 weeks. So if you look at, there's data that shows that maybe patients are waiting 6 months when you look at the literature, but when you actually speak to providers in the North, some patients are waiting up to a year to be assessed with inflammatory diseases, which is, to be honest, unacceptable in Ontario. And when you compare it to Southern Ontario, that's where the stark contrast really becomes obvious. If you look at a place like Toronto or Hamilton or London, some patients are waiting only 3 to 4 weeks. So it's not fair and it's not equitable that based on where you live, you don't get access to appropriate care.
In our meetings with the Ontario policymakers and decision makers, Sahil, you've laid out for them, I think, a really well-defined chart or flow chart in terms of what an interprofessional delivery of healthcare can look like in arthritis. Can you just walk us through some of those key elements?
Yeah, for sure. So when we talk about interprofessional models of care, I think the way I like to explain it is I like to describe the first traditional model because that's what most of us are used to, most patients are used to, or providers are used to. So the traditional model is the patient goes to the primary care provider, family doctor, nurse practitioner, gets referred to the specialist, sees the specialist, and then a note goes back to the primary care provider. That's what's been happening across the province, across the country traditionally. What an interprofessional model of care is really a team-based approach to providing care to these patients. It's not new in terms of concept. It's been around in other specialties and in musculoskeletal care, and even in rheumatology to a certain extent. But what an interprofessional model is the patient goes to the primary care provider. They get referred to ideally a centralized triage program where all the referrals go into this central referral pool, not to a provider per se. You have either a rheumatologist or an allied health professional triaging that based on the information provided, so that patients that need to be seen urgently are seen urgently, and those that need to be that can potentially wait because it's not inflammatory disease can wait longer. Once they're triaged appropriately, they're then sent to the appropriate specialist or to an extended role practitioner, which is allied health professionals. Once they're assessed clinically by the allied health professional, then they decide whether it makes sense to see a rheumatologist. Does it make sense to go to an orthopedic surgeon, a neurologist, based on the presentation, or does it make sense to go to a self-management program and physiotherapy? And what this does is it ensures that the patient's not waiting 6 months to see a rheumatologist to just be told you actually need an orthopedic surgeon or somebody else. And it improves access to care because it improves how fast you can be seen by a MSK specialist. It ensures appropriate human health resources. You're seen by the right person at the right time. It results in cost savings to the system, but also better outcomes for the patient. And there's evidence to show that this team-based effort, or team-based model rather, really works. But the issue is getting sustainable funding and support for this model, which has been the issue, at least in Ontario.
Yeah, and I would like to remind our viewers today that the situation across Canada is similar to Ontario in that there are sort of a varying level or degrees of models of care implementation across Canada. And there's no standardized model of care in any province or territory right now. And that is something that we as a community, as an arthritis community, is talking to governments about. We've heard, about centers of excellence and national frameworks for other chronic diseases, certainly for cancer, for diabetes, and now we're seeing them emerge for mental health. But we still have so much work to do as it relates to a standardized model of care for arthritis. And it's something that we certainly encourage people to go to our website at Arthritis Consumer Experts to find out more about the work that we're doing and for them to get involved. In terms of getting involved, I know that the Ontario Rheumatology Association, the ORA, is very much in sort of deepening discussions with government about this issue. Where is that at currently in Ontario?
So the specific branch or committee of the ORA is the Northern Ontario Committee, which is what I chair over the last year and a bit, that has put together a business plan or a business case, expanding upon a model that already exists in little pockets across the province, across other parts of the country. And we call that the hub and spoke model, where you have a extended role practitioner, someone called an ACPAC therapist, who is a OT or a physiotherapist or a chiropractor or nurse who's in a 2-year master's level program to be able to assess these patients in rheumatology, musculoskeletal issues. And they were asking for them to be funded for in major northern hubs and work in a hub and spoke model. So they assess the patients in Northern Ontario and then liaise with a rheumatologist, usually in Southern Ontario because of the lack of rheumatologists in the north, to provide this team-based interprofessional care. An example of this already exists out of Sudbury with Jocelyn Murdoch, who's an Arthritis Society ACPAC therapist and has put together a great program, works with 7 rheumatologists in Southern Ontario, but is funded through the Arthritis Society, but really doesn't exist anywhere else in the north. And we're asking for the government to provide sustainable funding for this sort of model across 6 major hubs in Northern Ontario: Thunder Bay, Sault Ste. Marie, Sudbury, Timmins, and North Bay. This exists in orthopedics, but not in rheumatology. So we put together this business plan, Kelly, and we've gone to major stakeholders over the last few months, yourselves at ACE, CAPA, as well as the Arthritis Society and the Ontario Medical Association. We've got support from all major stakeholders agreeing that this model is what's needed to improve arthritis care. And we're going to be taking this to the ministry early in the new year with major stakeholders at the table to discuss with the ministry and really push forward this agenda for arthritis care and ask for funding in this part of the province to start off. Yeah.
Well, I think that's very exciting for our listeners to learn about, particularly those who are living in Ontario. And certainly we're very proud to be collaborating with you on this, and for us to be effective for patient and rheumatology and arthritis health professionals to be all in the room speaking at the same time makes our case that much more, I think, compelling and powerful. So we look forward to continued collaboration with you, Sahil. At the end of this, we're going to provide a few links in terms of where people can get more information. Is there information if they go to for instance, to the ORA website, can they find more information about this topic?
The ORA website has a few articles that our committee had written or I'd written on the model and some of the work as we progress through the year to inform our membership, the rheumatologists. I'm not entirely sure if it's accessible to the public, but I'm happy to share those articles that talk about the state of the North, the models of care, and the work that we've been doing so that you can also put it up on your website or share with your members.
Well, it's work certainly that we're focused on in terms of addressing, inequities in care, particularly as it relates to remote rural communities, Indigenous peoples. So we look forward to this continued collaboration with you and the ORA, and we look forward to receiving more news as you begin these, I guess, negotiations with government in the new year. And we'd really like to have you back to just let us know how that's progressing, hopefully in the first quarter of 2022. So thank you very much for joining us today, Sahil.
No problem. Thank you for having me again, and thank you for all the collaboration and support that you've provided in this project for the ORA and our committee. And I look forward to the work that we can accomplish over the next few months.
Together we will, and we look forward to speaking to you again. And thank you to our viewers for joining us for another episode of Arthritis at Home. We look forward to seeing you again soon. Thank you.